everyone, and welcome to today's Public Health Ontario rounds for this World Antimicrobial Awareness Week. This presentation is entitled Describing the Burden of Antimicrobial Resistance in Ontario. My name is Brad Langford, and I'm a pharmacist specialist at Public Health Ontario and have the pleasure of moderating today's session. So before we begin with today's session, I would like to respectfully acknowledge the territory from which we are presenting in Toronto is the traditional territory of the many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse nations, Inuit and Métis peoples. I also invite you to recognize the histories, languages, and cultures of the Indigenous peoples on which the land you live, study, and work. So a few housekeeping items. The chat pod has been disabled to limit any distractions during the presentation. So please use the Q&A pod if you have any questions during the session. A discussion and question period will follow the presentation. If at any point during the session you experience technical difficulties, please email us at capacitybuilding@oahpp.ca. I would like to state as the moderator of this session that I have no conflicts of interest to declare. And it is now my pleasure to introduce you to the speakers for today's session, Drs. Nick Daneman and Kevin Brown. Dr. Daneman is a clinician scientist in the Division of Infectious Diseases at Sunnybrook Health Sciences Center and is cross-appointed in the Institute of Health Policy Management and Evaluation at the University of Toronto. He is a senior scientist at ICES and a physician at Public Health Ontario. Using hospital, clinical trial, and population-based data sources, his research program aims to maximize the benefits while minimizing the harms of antimicrobial treatment. Dr. Kevin Brown is an infectious diseases epidemiologist and health services researcher at Public Health Ontario and the University of Toronto. He received his PhD in epidemiology from the University of Toronto and a Master's of Science in biostatistics from the University of North Carolina. He studies healthcare-associated infections and antimicrobial resistance with a focus on C. difficile. His research has focused on creating reproducible indices of antibiotic risk, understanding the role of built environment in infectious diseases transmission, and documenting geographic variation in diagnosis of infections, prescribing of antibiotics and outcomes. So with that, I will turn it over to Dr. Daneman to get us started.
Thanks so much, Brad. And thanks everyone for the invitation for Kevin and me to present on describing the burden of antimicrobial resistance in Ontario. We are excited to be able to share with you a series here of 4 individual Ontario-wide projects looking at issues around antimicrobial resistance, which are all tied together. Kevin will present the first one, focused on antibiotic susceptibility of urine culture specimens in Ontario. He'll then pass the microphone back to me for the next 2 projects where I'll describe prevalence and mortality of bloodstream pathogens, and then look at the association of AMR and mortality in E. coli bacteremia. And then I'll pass the microphone back to Kevin, where he'll talk about the future work where this will culminate in a clinical antibiotic resistance index. And these are all intertwined projects. And so hopefully along the way, we'll demonstrate the value of population-based AMR research and surveillance, describe some of the key data sources and methods that make this work possible, as well as highlighting some of the challenges of this approach. We were asked to characterize where all this work fits in the Pan-Canadian framework for action on antimicrobial resistance. These are the 4 pillars shown here. The most obvious one is surveillance, because we're trying to clean and harness this data to be able to do population-wide surveillance. We also feel that it's an important contribution to research and innovation, both innovation in the way we're doing surveillance, but also the data then provides the ability to produce other innovative work. And then even though it's indirect, it also supports those middle 2 pillars, because having access to this Ontario-wide microbiology data can help us pragmatically evaluate population-wide interventions in IPAC and stewardship. And so setting that stage there, I'll pass the microphone to Kevin to speak about the first project.
Thanks, Nick. I'm excited to be here as well. So I'll just get started. with this first slide, just looking at the how this work is being funded by CIHR grant for COMBAT-AMR. So COMBAT-AMR is a grant that we received in 2018 called Comprehensive Ontario Microbiology Laboratory Administrative Data for Antimicrobial Resistance. It's a mouthful, but it's designed to create that acronym that you see above. And so the objectives of this project were threefold, starting with identifying the incidence and prevalence of AMR in Ontario, and then to measure the attributable mortality of all forms of antibiotic resistance, and finally to combine this work to create an index of the total impact of antibiotic resistance in Ontario. And so, as mentioned above, this work is funded by CIHR initially, but has since also been funded by the NML and PHO. So I'm going to begin by talking specifically about antibiotic susceptibility to urine culture specimens in Ontario. This is work that's forthcoming in CMAJ Open. What we see is that about 30% of antibiotic prescribing is for presumptive urinary tract infection. And treatment for those urinary tract infections is often empiric and isn't necessarily based on local resistance patterns. In the United States, the Infectious Diseases Society of America and in Europe, for guidelines created by both of these bodies for uncomplicated UTI, emphasize the importance of accounting for local resistance. But we lack data on that resistance. So E. coli is a dominant uropathogen, just as background, and around 70 to 80% of urine culture specimens tend to be E. coli bacteria. And antibiograms, which are diagrams that look at the levels of antibiotic resistance in bacteria, antibiograms for urinary pathogens tend to just look at E. coli. And so E. coli guides that empiric treatment decision. But there's other approaches that have recently been developed, specifically looking at what is known as a weighted incidence syndromic combination antibiogram. And so the idea here is just to use the weighted average of all the different resistance patterns for the pathogens that show up in urinary isolates instead of just looking at E. coli. And so our objective for this specific project was first to measure the prevalence of antibiotic resistance in urinary isolates in Ontario, to look at the prevalence of susceptibility and resistance in outpatient, inpatient, and long-term care settings, and then finally to compare what the E. coli antibiogram looks like compared to the weighted incidence antibiogram. And so this work is based on several different data sources, but what makes all of this work possible is the Ontario Lab Information System, and this is where we have been working to develop clean culture and susceptibility data. I'm going to speak more to that in subsequent slides, but we also link to other data sets that are held at ICES, including the Registered Persons Database and the Discharge Abstract Database. We use that data to identify covariates, including age, sex, setting, healthcare region. And in this study, we are looking at 6 different antibiotic resistance susceptibilities or results for 6 different antibiotics, including ampicillin, nitrofurantoin, TMPSMX, ciprofloxacin, aminoglycosides, and cefazolin. OLIS data is massive. Even the microbiology data, which is the fourth largest data set, has over 70 million unique observations or observations in this time window up to 2015. So this just gives you an idea of kind of the scale of the laboratory data that is now available at ICES. So ICS structures the OLIS, the Ontario Lab Information System data, into three linked data tables. Those three linked data tables include the observations table. So this is the most granular level of data and includes the free text result of the Ontario Lab Information System results. It also has some variables for the specimen source and for the timing of the result. These observations are nested within test requests, which are themselves nested within orders. And the data tend to be or are classified, or the lab results are classified using what are known as logical observation identifiers, names, and codes, so LOINC codes. And these can be used for identifying culture and susceptibility data in OLIS. So I'm going to show you some of the LOINC lists that we have been using to identify culture and susceptibility tests in Ontario. You see that culture results have distinct specimen sources by the LOINC. So this is an additional way that we can get information on specimen source. And then we have the susceptibility results, which include one unique susceptibility for each antibiotic. In terms of the complexity of these data, the culture results are very complex. When we just had a look in 2014 at some measures of the complexity of the susceptibility data, there are over 63,000 unique culture results. So about 1 in every 70 records is unique, meaning that there's relatively little standardization of how those data are being outputted. The culture results include that information on the specific organism. Whereas the susceptibility results, on the other hand, are much more standardized, even though they nevertheless include over 2,200 unique values. Only 1 out of 1,700 records are unique in terms of the susceptibility data. So when it comes to coding, we've implemented pretty simple algorithms using regular expressions. So what we do is we search the free text fields for unique organism names, and we've curated lists of bacteria that are of interest, that are of clinical interest, and we search for those names. We also use SNOMED codes that some laboratories are using to encode the names of different bacteria. And we search those free text fields for those organism names and encode based on that. Susceptibility test results are relatively simpler to code. We search for terms related to susceptibility or resistance, as well as intermediate. For the most part, the vast majority of results are susceptible, intermediate, or resistant. Some labs also provide MIC values, but those labs are also providing a kind of a result based on this ordinal approach as well, that includes susceptible, intermediate, or resistant. Using our imputation approach, the next step that the next data issue that we have to address at this point is that we have to run an imputation algorithm. That imputation algorithm is necessary due to some missingness for certain antibiotics that get reported, and sometimes that we've already done some preliminary work that has a real stewardship bent, looking at variability in reporting of isolates in Ontario, seeing a lot of variability in that reporting across labs. This is work that was led by Brad. Anyhow, because of this variability in reporting, we have to impute data for people missing certain susceptibility results. And we've done this using 3 different models, basically a complex model, ranging from a relatively complex model to a very simple model, depending on the amount of data. And the general idea is that for each organism and antibiotic, we're using information from other organisms and antibiotics to infer what the susceptibility of that given missing value is likely to be, and we choose the most likely missing value, whether it's susceptible or resistant. So I'm just going to continue along and finish up this description of our project looking at urine culture susceptibility results. So we're back to this very specific project looking at resistance patterns or susceptibility patterns in 6 different antibiotics. And so this project was based on data from 2016 and 2017, and we had 2.1 million unique culture orders from that time period, and 690,000 unique culture results when we looked at when we only included a single unique culture per patient per organism per year. And across those 690,000 culture results, we observed these patterns of susceptibility. So in general, what you'll notice is that susceptibility to the 6 antibiotics is substantially higher in outpatient settings and is substantially higher in the E. coli when you look at E. coli alone, as opposed to WISCA, the weighted incidence antibiogram approach. In particular, the differences are most prominent for inpatient samples between WISCA and E. coli, and they're far more similar in outpatient settings. In outpatient settings, 5 of these antibiotics had susceptibility levels over 80%, and it was lower in inpatient and long-term care settings. We also had a definition of multi-drug resistance, which was resistance to at least 3 antibiotics. And what you'll see on the right is that when we looked at, once again, when we looked at outpatient compared to inpatient, multi-drug resistance was more than twice as high in inpatient settings compared to outpatient settings. So in terms of the discussion, what we saw was in outpatients, 80 to 85% of positive urine cultures were susceptible to these 5 antibiotics, and WISCA and E. coli yielded similar results in outpatient settings, whereas the E. coli antibiogram really seemed to underestimate resistance in inpatient settings. And so this project has really shown the value of harnessing population level susceptibility data and tailoring, and it will enable us to tailor antibiograms to local populations to support improved antibiotic decision making. All of this data is already available to all Ontarians, including clinicians, and you can find it at our ASP comparison tool website. And I'll now just pass it on to Nick, who's going to talk about the prevalence and mortality of bloodstream pathogens in Ontario.
Thanks, Kevin. And we had started with urine cultures because they're the most common bacterial culture and susceptibility specimens in the province. But then we moved on from there to blood cultures, second most common and also a much more severe site of infection. And the next project that I'll present after this one is where we'll get back to antimicrobial resistance. But the first step here was just to be able to describe how common and how lethal each type of bloodstream pathogen is in the province. So the rationale here is that bloodstream infections are common and lethal, 600,000 cases per year in North America, 90,000 deaths per year in North America, and they are a top 10 cause of death, in many cases a top 7 cause of death. And because of their importance, there have been a number of surveillance networks established to try to track bloodstream infections, but they're very limited. They tend to rely on voluntary contributions from sentinel participating hospitals. These are usually large academic hospitals, collect up their blood culture isolates and send it to some reference laboratory. In addition to the difficulty in terms of labor intensity and financial costs, there's also a selection bias here with underrepresentation of non-academic hospitals. Even more so, underrepresentation of bloodstream infections occurring outside of the acute care sector. Also, when these isolates get sent to some reference lab somewhere, it's usually just the bacteria that goes, and it's separate from useful information on patient characteristics and outcomes. In Ontario, as we've shown you, we now have cleaned OLIS population-wide data, and it's not just acute care hospitals, it's across all the sectors. And because it's linked within ICS to healthcare data sets, we can connect this to patient characteristics, patient outcomes, and then importantly, to both together. And so the objectives of this project was to quantify the prevalence of bloodstream infections across all health sectors in Ontario, examine the relative prevalence of different organisms, and also examine the odds of mortality associated with each one of these organisms. So we did this after cleaning our first year of blood culture data. That was calendar year 2017. We didn't look to earlier years of OLIS data because hospitals were only signing up sequentially, and it was only by 2017 that we felt we had comprehensive data. And so most of this comes from OLIS, as Kevin described, with linkage to other important ICS data sets like CHI for hospital data, NACRS for emergency department data, and also the registered persons database for survival data. We defined a blood culture episode by clustering blood cultures within 7 days of each other into individual episodes. We required 2 positive sets if the bacteria that was found is one that's a common skin organism and often contaminates blood cultures, such as coagulated negative staphylococci. And then we can really look at hundreds of organisms in these data, but for ease of display, we aggregated up to the genus level, with the main exceptions being that we look at some individual staphylococcal and streptococcal species at the species level. We divided by the registered persons database denominator of 13.2 million people in Ontario to calculate population rates. And then we looked at the adjusted odds of mortality in 2 different ways with 2 different comparators. The first was that we compared people with blood cultures positive for a given pathogen compared to patients with negative blood cultures using logistic regression and accounting for age, sex, location, and number of days in hospital in the last 90 days. This is important because the act of getting a blood culture marks someone as someone with higher mortality. You have to be pretty sick usually to have a blood culture sent compared to someone who doesn't have these sent. But then we also wanted to compare it to Ontarians without bloodstream infection without requiring that they have a negative culture. And here we hard matched people with positive blood cultures to 10 other Ontarians with the same age, sex, healthcare location, comorbidity score, and hospitalization experience. And I'll show you those results in a bit. So there were, just an example of the huge data. This is only 1 year, and there were 531,000 blood cultures, about 253,000 blood culture episodes, of which most were able to analyze, and 9.1% are positive for 22,935 bloodstream infection episodes. And because we can link to patient characteristics, we can look in subgroups, such as by patient age, sex, days in hospital, and location here, both in terms of who and where blood culture episodes happen, and also who and where positive bloodstream infection episodes happen. I won't highlight all of these, but just to show it, if you look at the bottom for location, up more than 1/3 of cultures are collected in a community. These are obviously less likely to be positive, whereas positive bloodstream infection episodes, about 3/4 happen in acute care hospital wards or intensive care units. The overall rate was 150 episodes per 100,000 patients per year. So this is a common disease. E. coli is the most common organism at the top there. Again, we've lumped up to the genus level just to be able to fit this on a page, but we could dig down further to further granularity if people are interested in certain pathogens. E. coli occurs at a rate of 40 per 100,000 population per year, and the number 2 is Staph aureus. And linkage also helps us describe these patterns. So you can see here graphically how across the age spectrum, in brown, streptococci predominate in young people, E. coli common in newborns, and then become less common, but then increase as we get to older age, for example. And then we can look by how long people have been in hospital, sex, location of blood culture collection. Also, because we can link to outcomes, we can describe mortality rates after individual pathogens. And most active surveillance systems or prospective cohort studies can follow people to hospital discharge, for example. But the beauty of administrative data is it doesn't cost more money to follow people out for a year. So you can see here we can report not just 30-day mortality, but 60, 90, 365-day mortality. And so for Staph aureus at the top there, for example, if you have that in someone's blood culture, there's a 40% chance that they won't survive the full next year. Of course, those are crude mortality rates, but we wanted to look at how serious these pathogens are after accounting for rich patient characteristics, and we did this in 2 ways again. First, compared to people without bloodstream infection, and then specifically compared to people with negative cultures. And you can see about a 2.6-fold increased odds of death for people with bloodstream infection compared to other Ontarians without bloodstream infection. The adjusted odds ratio is lower when we're comparing to negative cultures because negative cultures are sent in other sick people with pulmonary emboli and myocardial infarctions, for example, but still a substantial increase in adjusted odds of death across all pathogens, 1.47. We also found huge variability across pathogens. So Clostridium species had a 7-fold higher mortality compared to people without bloodstream infection. The one fungal pathogen, Candida, which makes it onto this top list, also has a very high adjusted odds of mortality. Some individual species stand out, like among the streptococci, group A strep, Streptococcus pyogenes, high adjusted odds of death. Staph aureus, again, is a standout as well. And then we thought it'd be nice to look in multiple dimensions, in fact, 4 dimensions here, to put this all together and identify our biggest public health threats in Ontario in terms of bloodstream pathogens. So on the x-axis is the number of episodes in 2017, the study year. E. coli, furthest to the right, had the most episodes. On the y-axis is the crude percent mortality at 30 days. So you can see Clostridium had the highest case fatality rate. The size of the bubble is the number of deaths occurring within 30 days in someone with one of these pathogens in their blood. And then the color of the bubble is the adjusted odds of mortality compared to patients with negative blood culture. And so you can see one real standout here is Staph aureus across all dimensions. Lots of cases, high case fatality rates, lots of deaths occurring after Staph aureus bloodstream infection, and a high increased adjusted odds of death, as compared to, for example, E. coli, which didn't carry a very high adjusted odds of death compared to negative cultures. So to summarize this project, bloodstream infections are common, 22,000 plus episodes per year in Ontario, and 150 episodes per 100,000 people, with a very high adjusted odds of death compared to people without bloodstream infection or compared to people with negative blood cultures. This burden varies by pathogen, and Staph aureus stands out as a high burden pathogen across multiple domains. So as a next step, we wanted to look at the impact of antimicrobial resistance in impacting outcomes for people with this severe infection. We want to do this across all bugs and drugs, and Kevin will come back to that later, but because that's so complex, the place to start was with E. coli. So the rationale for this study is that we need to know more about antimicrobial resistance and mortality. The best study published on this topic to date is probably this great paper from Lancet earlier this year by the Antimicrobial Resistance Collaborators, gigantic international collaboration. They looked at the impact of AMR mortality using calendar year 2019, estimating deaths and disability-adjusted life years attributable to and associated with antimicrobial resistance across 23 pathogens 88 bug drug combinations, data from 204 countries, and 471 million individual isolates. And they estimated from all that there are nearly 5 million deaths per year associated with bacterial AMR, and more than 1 million deaths attributable to bacterial AMR already in 2019. In that data, E. coli was the #1 pathogen with the most associated and attributable deaths. And they had massive data, like I said, 471 million isolates. But when they went through their 10-step study method, it was the step where they had to look at the relative risk of death for drug-resistant compared to drug-sensitive infection, where they found the scarcest data, as our poll was suggesting. And so that's where all these estimates are tough to know how close they are to reality. And the reason for that is most regions can access their microdata, but they're unable to link that microbiology data to patient characteristics and outcomes. And so our objective, now that we can do that here, was to focus on the most common pathogen, E. coli, and look at the extent to which AMR is associated with an increased odds of death in the context of our well-resourced Ontario healthcare system. So a retrospective cohort study, all Ontarians with E. coli in their blood, now looking at 4 years of data, because by this point we had cleaned 2017 to 2020. And by the way, 2021 will be imminently available as well. Same data sources as that last study. And our primary predictor of interest was antimicrobial resistance. And we tried to do better than most studies which focus on just one type of resistance, for example, ESBLs versus no SBLs, by looking at all the classes of agents that we commonly use and commonly test. Aminopenicillins, first generation cephalosporins, third generation beta-lactam, beta-lactamase inhibitors, carbapenems, fluoroquinolones, aminoglycosides, and sulfonamides. So that there were 8 different ones that we looked at. We also had a 9th category called difficult to treat resistance, borrowed from some previous investigators in the US that had created this term, which was, an organism that's resistant to carbapenems, fluoroquinolones, and at least one of third generation cephalosporins or beta-lactam, beta-lactamase inhibitors. And the name, as it suggests, means these are really difficult to treat. You have to use either toxic drugs like aminoglycosides or difficult to access drugs. And the challenge, just as Kevin was describing for the urine cultures, is that because this is not active surveillance with a reference lab, we're dealing with laboratories that don't test and all report the same panel of antibiotics. And even within a laboratory, reporting might be variably suppressed or released. So a lab might not release the meropenem result for E. coli unless it's resistant to a few of the first-line agents. And so this is really one of the biggest front-loaded challenges of using routinely available microbiology data. And our solution, as Kevin showed, is imputation. So first, there's rule-based imputation, where we know that we can infer some results from the available results. So if they've reported that it's ampicillin sensitive, then we know it's piperacillin tazobactam sensitive, even if that hasn't been reported out. Or some resistance results can be inferred the same way. That still leaves some missing data, a minority, but still important missing data. And so that's where the model comes into account, a logistic regression model, accounting for the overall rate of susceptibility to that antibiotic and the results that are available, but also accounting in that individual test for the patient's age, sex, location, and the results of other antibiotic classes that were reported. So that's how we get antibiotic resistance. And then our primary outcome is 90-day mortality. And then the analysis is to look at it unadjusted. So each of those 8 drugs separately and DTTR, so 9 different unadjusted looks at the association between resistant versus susceptible E. coli on 90-day mortality. And then to do that for each of these 8 drugs and DTTR in 9 different multivariable logistic regression models. Here, accounting for all these things that could confound an association between antimicrobial resistance and mortality. Patient age, sex, where they were when they were blood cultured, total days they spent in hospital in the last year, total days in ICU, total days in long-term care, numbers of physician visits. The source of bacteremia is from a urinary tract infection or another source of bloodstream infection. Are they immunosuppressed? And also 18 individual comorbidities were in this model. And so we had 14,500 eligible E. coli bloodstream infection episodes and 13,000 plus patients. Most are in hospital wards and ICUs, but 16% community onset. Median age was 74, over half were women, and urinary tract sources are responsible for nearly half of these E. coli bloodstream infections. And these are the resistance rates to our 8 common treatment classes, as well as for DTTR. You'll see 4 bars for each one, because we have our main analysis, but we also tried different approaches to dealing with the missing data, assuming they're all susceptible, deleting them all together, assuming they're susceptible in the same proportion as the available results. The shading doesn't matter so much because you can see the bars are similar height, which makes us feel comfortable because these approaches are robust to the different imputation methods, it looks like. You know, resistance rates are high to some of our commonly used empiric treatments. So for 3rd generation cephalosporins, like ceftriaxone, and beta-lactam, beta-lactamase inhibitors like tazobactam, probably the 2 most common things we would use empirically in someone sick with E. coli in their blood, have resistance rates exceeding 10%. A little bit reassuring is that we have very low resistance rates to carbapenems, and you can't even make out a bar for difficult to treat resistance because only 0.2 and 0.1% met these criteria. And then here's the main result. The odds of mortality associated with resistant versus susceptible E. coli bloodstream infections. In blue are the unadjusted results. In red are the results adjusted for that rich array of patient characteristics. So you can see it, very, very high magnitude adjusted odds of death, or I shouldn't say just odds of death in patients with resistant versus susceptible infections across all drug classes in those blue dots. That association attenuates pretty substantially once we adjust for how old that patient is, how sick that patient is, and how much they've been utilizing healthcare in the last year. And so the red findings all drop back towards 1. But the point estimates are all greater than 1. And many of these remain statistically significant even after the substantial adjustment. So for example, for 3rd generation cephalosporins and beta-lactam, beta-lactamase inhibitors, there's adjusted odds ratios of 1.29, 1.28. So, you know, an almost 30% increased risk of death in people with E. coli bloodstream infections resistant to these drugs. And so, two slide discussion. I just want to say that, again, antimicrobial resistance surveillance can harness routinely available data. But the main challenge is that not all labs report the same panel of antibiotics, and we can overcome this with imputation. AMR has not yet progressed in Ontario to the extent that we don't have effective therapeutic options for patients. We don't really have untreatable infections very commonly here. There are only 18 patients with a DTTR E. coli. But E. coli resistance is substantial for our most commonly used empiric agents. And some of those numbers are scary. And it was associated with increased mortality for patients with E. coli bloodstream infection across most of the agents, and especially those that we use commonly for empiric treatment. Also, we found that adjustment for patient characteristics, and in particular adjustment for prior healthcare utilization, which most regions can't do, really attenuates the association. And so most existing studies underadjust, and so most literature overestimates the current burden of AMR. Nevertheless, AMR is certainly a global population health threat and is already associated with substantial mortality risk in our province here. And I'll pass the microphone back to Kevin for the 4th and last project for description.
Yeah, so this is really just going to be a review or a discussion of, you know, what we're planning to do in the upcoming year or so of this project. So what we've seen is we can estimate the mortality impact of specific forms of antibiotics for E. coli bloodstream infections. But from a public health perspective, we're certainly interested in antibiotic resistance to all forms of resistance. And so in our next round of modeling, what we're going to be looking at is exactly that question. So we've outlined 46 bacteria that we plan to look at with exposures to around to 16 antibiotics for each of those bacteria. And we'll be looking at in total over 760 bacterium antibiotic pairs, and we'll be looking at 90 and 30-day mortality for that work. just as we did in the work that Nick just presented on E. coli, we'll be looking at risk ratios for each bacteria antibiotic pair and for specific forms of multi-drug resistance, as was outlined for that difficult to treat resistance category. But then the question is about how do we combine all of these? And so we have this, what we've been calling the clinical antibiotic resistance index. So this resistance index that we plan to develop, which will be basically measuring the incidence of mortalities as if we'll create kind of a simulation, actually, where we measure, based on the models that we've developed, measure the incidence of mortality that we would expect if we imagine that everybody had a susceptible infection. And then we'll also do the same thing all over and look at the expected incidence of mortality if people had the observed resistance patterns that we see. So that's the as-is mortality. And then we'll sum across all of the, antibiotic, the organism antibiotic pairs, those 760 specific pairs to measure the total burden of antibiotic resistance in Ontario. So just going to wrap up now. So some of the main points of this talk were that we have millions of routine microbiology testing results that are unharnessed in individual lab archives. We can amalgamate this data, but it requires a massive amount of upfront work to clean, impute, and link to administrative data sets. But this work is really essential to combat the global public health threat of antibiotic resistance. And then, so we know that centralized population-wide microbiology data linked to clinical data provides comprehensive information on pathogens and resistance. It's not limited to just sentinel or voluntary hospital sites. Many of the projects looking at antibiotic resistance in Canada at the moment are limited to a number of hospital sites. Our data span acute care, long-term care, and the community. And it really provides the potential for timely surveillance data that could be provided to facilities as well as at the regional and provincial level. And so we really think that this data and this approach that we've outlined has the potential to make Ontario an epicenter of antimicrobial resistance, surveillance, and research. And with that, I'll hand it off to Brad for the question and answer period.
Great, thanks so much, Nick and Kevin. That was an excellent presentation, really exciting work. And you can see how there's endless research questions and surveillance types of questions that can be answered with these data. So we do have some time now to move to the question and answer pod to address some of the questions. And there were a couple of questions in there, but please feel free right now to ask any questions in the Q&A pod, and we will get to them. I see that there's a couple of questions that had been answered, and I just wanted to see if either of you wanted to elaborate on any of these answers. A great question from about imputation of missing results, and how do you handle when certain susceptibility results may be suppressed. And so Kevin, you indicated that there is a covariate for a missing antibiotic. Did you want to add anything to how we address those missing data?
Yeah, so we could actually look at what the missing data was implying in the data by including missing data for other categories as a predictor for this given form of resistance. So it's definitely something that we thought about. And actually, we did a whole study looking at patterns of reporting in the susceptibility data that you spearheaded, Brad.
Great, thanks so much. So there's also a question in the chat that was answered about hemodialysis population. So Nick, you had answered that yes, in fact, we do include hemodialysis patients, but we haven't looked at them yet as a separate subgroup. There is a question now in the chat from, would advocacy for working on a standardized way of entering lab data support this type of analysis and reduce the work involved, similar to what's used with the ICD-10 codes? If yes, is this something that has been explored or could be combined with the current work to create a new system for reportable diseases in Ontario, public health system, which will have an OLIS feed? Resistance results are utilized for some reportable diseases like gonorrhea and TB. I wonder if, Kevin, you want to take a stab at that?
Yeah, it would be incredibly helpful for this, and there isn't really the need for a new system to be developed. It would be done through it would probably be done through LOINC, and I think people have learned the advantages of standardization over the course of the COVID-19 pandemic, because in public health we were leveraging OLIS actually to pull data on COVID-19 test results. So hospital laboratories were given very specific instructions on which exact LOINC codes to be using and how to code the result. And if something could be done of that nature for culture and susceptibility test results, it would, it would massively improve the reliability and the ease with which this was done, and kind of the required maintenance. So it's all about, it would be amazing to be able to kind of engage our lab partners to come up with some standards for how to report culture and susceptibility results. But I don't think a new system is required. It's something that could be built into the existing codes, just more specificity on which specific code, LOINC codes to be using and how to code the free text result.
Thanks. There's a question, this is a really interesting question about, are there enough data to report on antimicrobial resistance to H. pylori in Ontario? And I think this question has come up in the past with us at PHO in terms of the susceptibility testing is not commonly done, and it's often done in reference labs. So is there enough data on it? Nick, I don't know if you've seen anything in these data, or Kevin, that look at H. pylori as an organism in terms of susceptibility results.
Yeah, I mean, we certainly would have the ability to look at it, but so far we've only gone down, I think, as far as in blood down to 88 organisms, and in the urine, we had only gone down, I want to say, into the 40s to 50s, although it's too long ago for me to remember the exact number. And only now are we moving from urines and bloods, which is where Alex, Marcia, and Austin had started all this from, and Daniel Friedman has taken over those, and is now, we're trying to expand some of those techniques to other culture types, and we may be very close, but it's hard to know at this point. But once we can get to other specimen types, we'll be able to look at how common H. pylori is as an organism and how often that is accompanied by susceptibility result.
Thank you, Nick. So I have a question of my own. I just wanted to know a little bit about, the fact that we're hearing a lot about rising rates of antimicrobial resistance in the population, specifically and particularly after COVID-19. What efforts, if any, are there to look at these data sets to evaluate trends in antimicrobial use over time, whether it pertains to COVID-19 or beyond? Maybe I'll direct that to Kevin first.
Sure. I mean, I think the data up to 2017 was kind of getting more and more complete, but moving forward, obviously, we'll be able to look at trends of all sorts.
And there are, one other downside of the administrative data is there is a time lag from when it becomes available at ICS. So for example, for the CI data, there's a longer time lag. Ontario Drug Benefits data, there's a shorter time lag. For OLIS, I think there's a quarterly update, and it's only getting better with time. So there is the potential for temporal trend surveillance to be something that could be done quite fast and efficiently by this method in the future.
Great, thanks so much. I don't see any additional questions in the Q&A, so I think we are able to wrap up at this point. So I'd just like to thank Nick and Kevin for the really excellent presentation. I also want to thank everyone who joined us for the session. You can expect to receive a brief and anonymous PHO round survey for this session, so please try to complete it to help us improve our future programming. And lastly, to access PHO rounds presentations and view any upcoming presentations, please visit the PHO website. You just have to go to Education and Events and click on Presentations. So thank you everyone and have a great day.